All right, so we're going to get started. I want to thank everyone for joining us today. Thank you, Dr. Hwang, for being able to do this webinar for us. I also want to apologize for the time change for everyone, and I'm sorry for those who weren't able to make it, but I'm really glad for those of you who are able to make it. We're going to have the webinar up on our website too, so if any of you have to get off early or have any conflicts later on, you will be able to access it on our website from the end of this moving forward. Sure. And so I just want to thank Dr. Love and Dr. Hwang for being able to do this webinar. And today we're going to have a conversation with slides from Dr. Hwang from her study and questions facilitated by Dr. Love. Just a little bit about Dr. Hwang. She is Chief of Breast Surgery and Professor and Vice Chair of Research at Duke University Department of Surgery, where she leads translational research activities in early stage and in situ breast cancer. Dr. Hwang has received local and national recognition for both her clinical expertise and research to improve both cancer and quality of life outcomes in patients affected by breast cancer. Her research interests include establishing feasibility for less invasive treatments for pre-invasive breast cancers and identifying tumor and stroma-associated determinants of cancer progression, which could be targeted for breast cancer prevention. She is the PI of a national cooperative group study evaluating the role of preoperative endocrine therapy for low-risk DCIS, as well as a national recognized controlled trial of active surveillance for DCIS. Her laboratory is focused on understanding the evolutionary basis of cancer progression based on mathematical modeling in cancer genomics. She also leads a team which seeks to re-enter electronic data systems to improve delivery of breast cancer care. She serves as a member of the NCI Breast Cancer Steering Committee, the NCCN Breast Cancer Steering and Diagnosis Panel, and co-chairs the local regional working group of the Translational Breast Cancer Research Consortium. Her research is supported by the NIH, DOD, PCORI, the Susan G. Komen Foundation, the Breast Cancer Research Fund, and the American Cancer Society. Thank you for joining us, Dr. Hwang, and for everyone on the call. If you have questions throughout the webinar, please fill them out in our questions tab on in the webinar side. And if you have questions at the end, where we will be answering questions, please do the same, and we will make sure to try to get to all of your questions. All right, and with that, and Dr. Hwang, you can start your presentation.
Okay, great. Thanks, Amaka. I'm getting tired hearing that introduction. But thank you so much for the kind words. And I just wanted to thank you mostly for the opportunity to speak on this webinar today. Dr. Love and I were just chatting before I think the rest of you joined the call. And, you know, a lot of times when we do research and patients contribute to research, the patients who participate never really know what the findings are and what happened to that tissue or that information or that survey. And I think what I love about the Army of Women is that it just gives researchers an opportunity to, number one, thank people who participated in the survey, and number two, just share the results of what we found, because I think that's how people get engaged and interested in participating and wanting to have greater participation in research, which is really how we push the field forward. So thank you, first of all, to those of you who are on the call, especially those of you who participated in the survey. I hope you'll be interested in what we found. So the title of the talk today is Patient-Reported Outcomes After Choice for Contralateral Prophylactic Mastectomy. And hopefully you can see my slides. The first one is a woman who's wearing a flowered dress, and the caption at the top is "No regrets after double mastectomy, but questions remain." And this has to do with a write-up that the New York Times did on our paper, again, from the results that we collected from the survey that you all filled out. And it garnered quite a bit of national interest just a few weeks ago. So this is all just kind of hot off the press, and hopefully you'll find it interesting. But basically, the meat of the story and the intro to it was that Ronnie Rabin, who did the interview with me, started off by saying, Ms. Foldis is one of a growing number of women opting to have both breasts removed after a diagnosis of breast cancer in only one breast, even though doctors say the operation does not improve the chances of survival. Now, a new study based on surveys of thousands of women, so those are the women in the army of women, suggests that women who have double mastectomies also do not benefit from the big improvement in quality of life either. So I'd like to just spend a few minutes this afternoon walking you through the study itself and what we found. So the context of the study is that if you look on this chart from 1998 to 2011, and we look at the largest database in the country of cancer, breast cancer treatment and outcomes, called the NCDB, we can see a few trends about the kinds of treatment that women are choosing for their early stage breast cancer. And when I say early stage, it's usually refers to stage 1 or 2, sometimes 3, but definitely curable breast cancer. And in the 1990s, a lot of women, so if you follow the blue line up on top, more than 65% of women were having breast conserving surgery or lumpectomy for treatment of their early breast cancer. But when you start following it out to about 2008, 2009, 2010, you can see that that number has actually come down a little bit, so now it's closer to 60%. So clearly a lot more women who were getting lumpectomies before are now choosing to have mastectomies. And this is an observation that's been made by quite a few people in the last 10 years. And on the part of breast surgeons, and Susan can attest to this as well, every time we go to a breast surgery meeting, a lot of us are concerned about the fact that women are choosing to do a lot more surgery than is actually required to treat their breast cancer, and we're always very curious about what motivates women to make that decision, and then also what happens after women make that decision. And here in this slide, you can see that in a very similar study, if we look at the trend of women who underwent mastectomy, you can see that that really looks like it's the women, so the top curve is just women who underwent mastectomy for one breast, and that trend is definitely coming down. So in 1998, again, most women who were having mastectomy for breast cancer were only having that diseased breast removed. But if you follow this trend out now to 2010, 2011, about half the women who have a mastectomy for their breast cancer actually undergo bilateral mastectomies. So when you look at the curves on the bottom there, and can you see my arrow?
Yeah, we can actually.
Oh, okay. All right, so when you look here at the yellow circle, so these are women who are undergoing bilateral reconstruction, that trend is definitely going up. But also patients who are undergoing bilateral, so removal of both breasts with no reconstruction, so in these blue triangles, that trend is going up as well. So clearly all of this together just indicates that a lot more women are undergoing a lot more surgery for what was originally primarily treated with a lumpectomy. So one of the reasons that it's possible that women are choosing to make this decision, and I'd be very interested to hear from all of you on the call, particularly if you've made this decision, is that women perceive that they're just going to do better overall. And one of the most common things I hear from my patients is, I don't care what you have to do, I just want to live long enough to see my blank, child graduate from college, see my first grandchildren, see my kids getting married. They all want to live for as long as they can, and that's the justification for wanting to have both breasts removed. but there are many studies now that have shown these very similar results, that if you look at women, whether they had estrogen receptor negative cancer, so that's the kind that does not respond to hormone treatment, or whether you have estrogen receptor positive cancer, so those are the tumors that do respond to estrogen blockade. It doesn't matter what kind of cancer you have, the overall survival, so how long you live after your diagnosis of breast cancer, whether you have a CPM, so the other breast removed, contralateral prophylactic mastectomy, or no CPM, you live exactly as long. Now, if you just look at the number of years you live being free of cancer in the other breast, the curves split apart a little bit, and it looks like the patients who have the other breast removed might do a little bit better. So at 20 years out, the curve up on top, which is women who undergo a prophylactic mastectomy, is a little bit better than women who don't undergo a prophylactic mastectomy. But since these curves come together in terms of overall survival, even if you do get a second cancer, people don't die of that second cancer. They do actually very well and live just as long as if you had the opposite breast removed. So again, that shows true for patients of all ages, all different kinds of tumors, and this has been shown in multiple different studies now. So what we were interested in this study was that given there's really very little benefit in terms of cancer survival, so your likelihood of living for a long time after a diagnosis of breast cancer, is the choice for a contralateral prophylactic mastectomy, or CPM, or removal of the healthy breast, is the choice for CPM supported based on improved quality of life for patients undergoing CPM? So if you state it another way, we understand that patients don't live longer, but do they live better? Do they have a better quality of life? And the method that we chose to look at this question was that we administered a web-based survey to collect patient-reported outcomes, or PROs, among women who had undergone breast cancer treatment using an instrument called the Breast Q. It's a list of survey questions that have been very specially designed to ask quality of life questions for women who'd undergone breast surgery. And what we wanted to do was assess the quality of life for women who had undergone surgery for breast cancer. And our goal in doing all this was to determine whether having a CPM affected quality of life outcomes. And the corollary of that is whether getting a CPM, if it didn't lead to a longer life, whether it could be justified on the basis of leading to a better quality of life. So what we did was we contacted the Army of Women, and we wanted to participate with them and all the women who were part of the Army to see if we could administer this survey. And as many of you know, the Army of Women was founded in 2008. And the goal of the Army was to try to partner together with breast cancer investigators and the Susan Love Research Foundation to connect the people who are doing the science and designing the studies with study volunteers. And there were many different ways in which these volunteers could help. They could take part in surveys like what we did for this study, but they also could be matched up, kind of like a Match.com, of people who had the particular type of breast cancer or the type of situation that a specific investigator was trying to study. And so I know of several different studies now, and Susan, I don't know if you want to jump in here, but it's actually been very successful in trying to partner investigators with the patients who want to volunteer for these kinds of research studies.
Yeah, absolutely. In fact, one of the reasons I started it is I kept complaining that all the research was on mice and rats who actually don't get breast cancer. And they have to humanize them sometimes to give them breast cancer. And I said, why not do it on women? And the researchers said to me, well, we don't know how to find women. And I said that I could do that. And that was the beginning of the Army of Women, because we really are the only animal other than domesticated dogs that naturally get, and macaque monkeys that get breast cancer. So we have to study us if we're going to understand it.
Right, and I think that's just particularly important when we're looking at things like quality of life, because unless you ask women who've actually been through the experience, it's really hard to get a realistic idea of what life is like after having gone through a diagnosis, after having gone through different treatments. And these large data sets that are available, like the NCDB, like SEER, they don't collect any quality of life data. So it was really important that we get directly in touch with women who had gone through these different kinds of procedures. So what we did was we had our proposal approved by the Army of Women, and we partnered together and we released a web blast that included a survey, about a 2-hour survey actually. It was quite a lengthy survey. And about 24 hours after we released that survey, or the call for participation, we got like 4,000 responses back. So it was just tremendous, and it really spoke to the power of being able to harness that kind of participation. So this is so there were 2 parts to this survey. One was a demographic survey where we just asked some general questions about the participants' breast cancer history, what kind of treatment they got, some demographic data in terms of what part of the country they lived in, whether they were in an urban or rural environment, a little bit about the kind of educational background they had, a little bit about income data, insurance data, race, ethnicity. And then the second kind of more extensive part of it, and for those of you who took it, you know it's quite a long survey, but that was the breast Q, which is a very formal list of survey questions that had to do with patients who had breast conserving surgery or lumpectomy, another set of questions for patients who had reconstruction, and then finally some that were specifically for women who'd had mastectomy. And we were interested in looking at how happy women were with the shape and the feel of their breasts after breast cancer surgery, and whether they could give us any insight about what their quality of life was after undergoing not only surgery but lots of other kinds of treatment that they had as part of their breast cancer. And this is a very busy, very small font slide, but it's just to give you some kind of idea about the kinds of questions that we asked all of you. If you look on the right, the columns are very dissatisfied, somewhat satisfied, and very satisfied. And we asked a bunch of questions like, how do you look in the mirror when you're wearing clothes? How do you look, how do you like the look of your breast when you're wearing a bra? Do you feel normal in your clothes? Do you like the size of your breast? So just very detailed questions. And many of you who responded actually completed the whole questionnaire, which was just awesome and really was the source of so many of the data points that we were able to get for this study. So we closed the study, I think, after about a week because after the first 48 hours, the responses really trickled off. So for the patients who were interested in participating, they just responded right away, completed their questionnaire, and there was really no reason to continue after a week because we really got very few responses after the first few days. But all told, we had a response from over 7,000 women. Almost 3,500 of you had breast conserving surgery or lumpectomy, and almost 4,000 underwent mastectomy, and that's the group that was the data source for the study that I'm going to describe to you. There were a group of women who had stage 4 breast cancer and were in a different group, so they weren't really included as part of this study. And then there were some patients who had ADH, which was not really cancer, but a risk factor for cancer. And then on the other extreme, they had inflammatory cancer. So for those patients, they had a very different kind of cancer experience than these patients in here. So these patients were also excluded. What we saw from the mastectomy patients was that the majority did not have CPM. So 2,300 did not have the other breast removed, but about 1,600 women actually had reported having received CPM, and of those who underwent CPM, it was almost half and half. Among those 1,600 women who underwent CPM, the majority actually underwent reconstruction, and only 300 or so did not undergo reconstruction. So I think this is where it gets a little bit confusing, but I'll try to walk you through this as clearly as possible. So I'm going to show you first the BreastQ module scores, and these are overall scores. So what the BreastQ survey does is it separates the quality of life components into 4 different categories. So the first is how happy are you with your breast shape and feel and just feeling comfortable with your breasts. The second component has to do with the physical component. Are you limited in any way after having undergone the breast surgery? Are you having pain? Are you having any limitation of mobility? Are you able to do everything physically you want to do? Yes, Susan?
Say again what CPM is. Somebody's asking because it's not intuitively obvious.
Yes. CPM is Contralateral Prophylactic Mastectomy, so removal of the healthy breast. So these are all women who underwent a mastectomy for the breasts that had cancer, and then there were a group of women who also had the normal breast removed in addition to the diseased breast. So those are the CPM patients. And those who did not have the non-diseased breast removed were the no CPM patients.
But the ones that did not have the normal breast removed all had mastectomies. They didn't have breast conservation.
That's exactly right. Yeah. So this was a group of women, all of whom had mastectomies for the side that had the breast cancer.
So, and are you going to compare against the breast conservations against the?
We actually published a kind of a small overview of that data set, but we can certainly go back in and do a more detailed analysis. This first analysis that was published was just looking at women who had a mastectomy and seeing if they had the other breast removed. It's not very common for women to have a lumpectomy on one side and then to completely remove the non-diseased breast.
No, but I was thinking the lumpectomy results against the mastectomy results, against the people who had mastectomies.
Yes, and actually we did start looking into that in the very first paper that we published out of this data set.
Okay.
And thanks for asking that question, because it's really important to understand the difference between the two groups if any of this is going to make sense. So I'm really happy that you stopped me there. So we were talking about the 4 different modules. So the first is breast, the second is physical, the third is psychosocial. So you know, do you feel sad? Do you feel depressed? Do you feel anxious? Are you happy? Are you satisfied with the decisions you made? I mean, those are the kinds of questions that would fall under psychosocial. And then finally, the last module that we were interested in was sexual functioning. So did women feel attractive? Did they, were they satisfied sexually? Did they feel that the surgery had any impact on their ability to be intimate? So all those questions fell under sexual. And these are just the scores that women got on all of these different modules. If you take all the questions and you mash them up into 4 different scores, these are the scores that we get. And just to give you some context, all of these scores are on a scale of 0 being the worst to 100 being the best. And so what we did was we compared the scores between women who had the healthy breast removed, the CPM group, to those who did not have the healthy breast removed. So if you'll just walking through here, if you look at breast satisfaction, the CPM group actually looked like they were a little bit happier with how their breasts looked than the patients who did not have CPM. This p-value here, the smaller the number is, the more likely it is to be a real difference between those 2 groups. So for the breast satisfaction, the CPM group did look like they were a tiny bit happier with the appearance of the breast than the no CPM group. Now in terms of physical function, it was reversed. So the patients who had CPM were a little bit less satisfied than patients who did not have CPM. So for that module, the no CPM group looked like they were a little better off in terms of quality of life. If you look at psychosocial functioning, that was pretty much the same between the two groups. So the fact that I didn't bold these numbers indicates that that probably was not a significant difference between these two groups. And in terms of sexual function, there also did not appear to be any significant difference between the two groups. Maybe I'll stop there and see if anybody has any questions that you might want to ask about this right now.
Let's see.
Okay, well, I'll keep going on if nothing immediately comes to mind, but as we're going through these results together, please feel free to just type and we can try to pick up that stream. Okay, so just bear with me a little bit because I think this is kind of important and I wanted to just be able to share these results with you as well. So then what we did was, that was in the overall group. If you take all the women who were in the group, that's what we found. Now in the next slide, what we did was we just took patients who didn't have breast reconstruction. So they either did or did not have CPM and did not have any reconstruction at all. And if you look at just that group of patients for breast, psychosocial, physical, and sexual modules, there was no difference whether you had CPM or no CPM. There really was no difference between the groups. But if you then looked at women who had breast reconstruction, what we found was that in terms of breast satisfaction, physical satisfaction, and psychosocial satisfaction, there was a significant difference, and it was in that same direction that I showed you before. So women were a little bit happier with their breasts, so there was a higher score in the CPM group versus the no CPM group. There was a lower physical score in the CPM group compared to the no CPM group, meaning that if you didn't have the other breast removed, you felt a little bit more physically fit. And then also, which I found kind of interesting, is that in terms of psychosocial functioning, how much anxiety you had, how much concern you had about the future, how happy you were with the decision that you made. So the CPM group was, again, a little bit lower than the no CPM group. So the only module in which the CPM patients, so the women who had more surgery, removed the opposite breast, the only module in which they did better was in those patients who had reconstruction. They were a little bit more happy with how their breast looked and felt. And that's kind of a lot of different analyses I showed you.
I wonder if some of the less anxiety is, I know there's a perception that if you take both breasts off, you'll never get cancer again, even though that's not entirely true. But I wonder if that gives you less anxiety thinking that.
Yeah, that would be the hypothesis, but what this data shows is that your psychosocial functioning, your anxiety is a little bit less. You're better off psychosocially if you don't remove the other breast.
So maybe that people who are anxious are more likely to do it. So maybe it's not the procedure that made them.
But them that made the procedure.
But then
yes.
The procedure, yeah.
Yes, in fact, I think that's what this shows, and I always like to kind of explain it to people that what this shows, in my mind at least, is that surgery is not the cure for anxiety. That by trying to remove the other breast, you're trying to remove your worry, but that's not a surgical, worry is not a surgical problem, and what we see here is that it looks like the worry certainly is not any better, and maybe even a little bit worse in patients who choose to have the other breast removed. So I'm sorry, I'm going in the wrong direction. Okay, so I just want to show these last two slides. I know that I've thrown a lot of information at you, but I think it's really important for all of you to be familiar with something called a multivariable analysis. And what that is what we try to do is we know that some things are related. So it may be that younger women are more anxious about their future. I'm not saying that that's necessarily true, but there could be factors that kind of track together. And a multivariable analysis tries to see if you kept all the other factors the same, which of the factors would still be different in the different groups. And although this is kind of a little bit of a complicated analysis, when we tried to do the multivariable analysis and we looked at physical well-being and psychosocial well-being, the women, and just look here where it says CPM, the women who underwent CPM had a score that was just a tiny bit higher in terms of physical well-being when you adjusted for everything else. But that number was not significantly different. It was such a small difference that it really didn't make a real difference at all.
So I'm going to just jump in and say, when we say significantly different, that's actually a statistical test that they can do to see whether it's by chance you would find that or whether it actually, there's something real there. So when you say it's not really statistically significant, that means there might be a slight difference, but it could be, it's most likely due to chance.
Yes, that's exactly right. And the reason these numbers are a little bit hard to wrap your head around is what this means is that if all other factors stayed the same, the people who had CPM would have a score that was 0.3 higher than people who did not have a CPM. So a number that's higher than 0 means that it is in the good direction, and a number that's lower than 0, like -2, means that it was in the bad direction. So let me see if I can try to explain this in a way that makes sense. So in terms of physical well-being, this small difference between women who did and did not have CPM probably is not big enough to make any difference in terms of physical well-being. But this last variable here, which is whether women had reconstruction or not, reconstruction tracked with a little bit less likely to be physically well off, to have a higher physical quality of life. Now, if you go to psychosocial well-being, again, keeping everything else the same, but only looking at whether women got CPM or not, it looked like women were a little bit better off with CPM versus those who did not if you keep everything else the same. But this number was really a small number. On the other hand, if you just looked at whether women got reconstruction or not, that is a much bigger number than if you get CPM or not. And it turned out that when we, again, kept everything else the same and just looked at women who did or did not get reconstruction, the women who got reconstruction were much more satisfied and much happier in terms of their psychosocial well-being than women who did not have reconstruction. So whether you have reconstruction or not makes a much bigger difference than whether you have a CPM or not, is what that showed it.
You didn't separate it out by the different methods of reconstruction.
Again, we have done that. We have some preliminary data that we've reported, but we did not do that for this paper. And again, doing that same sort of analysis, if you have a CPM, you're more satisfied with your breasts. But if you have reconstruction versus not having reconstruction, regardless of whether you had one or both breasts removed, you're much happier with the way your breasts look, which completely makes sense. I mean, if you have reconstruction, you're hopefully going to be happier with how they look than if you didn't have reconstruction. And in terms of sexual well-being, women who had a CPM had a lower sexual well-being score. But if you had reconstruction, these women did much better in terms of their sexual quality of life. So I think although this is just a lot of numbers to look at, the take-home message from this is that even if CPM improves some of the quality of life outcomes, it only moves it a little bit up or down. So little that it probably didn't make a huge difference. Reconstruction, on the other hand, kind of blew CPM out of the water, and whether you have reconstruction or not really profoundly affects how happy you are with your breasts, how happy you are with your sex life, how happy you are just overall in terms of your psychosocial well-being. And then speaking of psychosocial well-being, we were also interested to know, does it get better over time? Is there something to look forward to? Are you going to be happier 10 years from now than you are when you first get diagnosed with cancer and you go through all your treatments? And I think the good news is that whether you have the other breast removed or not, your psychosocial well-being is going to continue to get better. The further you are from your cancer diagnosis, just the happier you will be overall. There is a silver lining. And women make it through, and they have a much better and more rich quality of life the longer you are from your cancer diagnosis. And interestingly, we also looked at breast satisfaction of women who did and did not have CPM, and that didn't really seem to change much over time. So unlike psychosocial quality of life, you kind of are stuck with what you have at the time that you initially have the surgery. Whether you have CPM or not, we found that the patients ended up not being a lot more happy over time with the way the breast looked. And for those of us who've been in this field for a while, we know that women who've had breast surgery last year versus those who had breast surgery 15 years ago, you can't make any generalizations about who's necessarily going to look better. Okay, so I think I threw a lot of information at you. I'm very curious to know what kinds of questions you have about some of the things we found. But one of the first conclusions is that when we looked at this national cross-sectional survey of women who had breast cancer, who'd undergone treatment for breast cancer, we found that when we control for all the other variables, patients who had CPM had higher scores for psychosocial well-being and breast satisfaction. Although when you didn't control for all those other variables, it looked like the opposite was true. But in any case, that women who had CPM had slightly higher scores for both psychosocial well-being and breast satisfaction. But as we were talking about through the course of this presentation, the amount of the difference between women who did and did not have CPM was really tiny. And it was small to the amount that it might not make any real difference in women who choose to have the other breast removed versus those who choose to keep the breast. A much bigger difference in terms of improvement in quality of life resulted from whether women chose to have reconstruction or not. And then finally, what we found is that women who had CPM did not have a huge difference from those who did not have CPM in terms of how comfortable they were with their bodies and their sexual well-being when we controlled for all the other factors that can track together. So there wasn't really a lot of difference between the CPM and the no CPM group in terms of those different elements of quality of life. What we'd like to summarize from this study is that we're very interested in not only understanding whether patients live a long time, but whether they live with a high quality of life, because all of the things that we do impact patients in some way. If it's a trade-off between a poor quality of life and a longer life, I think it's something that women really need to understand as they're trying to make these decisions about what treatments are most in line with the way that they want to live their life. And as this realization becomes much more important, I think these kinds of survey data will become the kinds of things that we're increasingly looking towards to help our patients with the decisions they're making. And it'll be increasingly important to share the results of these types of studies with patients especially when we're in this particular study, when women come in, they expect that they need to have both their breasts removed as they want to live a long time, or they feel like they're going to just be happier if they have the other breast removed. I think what our study shows is that they might get a lot more benefit in terms of quality of life if they just choose to have reconstruction, even if they only have a mastectomy in one breast. And I think importantly, what I hope I've been able to convey is that the engagement of patient advocacy organizations such as the Army helps us all to better understand the impact of breast cancer treatment. And this helps us to inform treatment decisions for future women who are struggling to make the right decision for themselves in terms of breast cancer treatment options. So I don't need to state the obvious that we wouldn't have been able to do any of this work without the participation of Susan Love and the Army of Women. And I just wanted to give back in some small way just to let you know what a difference your participation makes and how some of the insights that we get into cancer treatment we would never be able to have without patient participation. So thank you.
Thank you. We do have some questions, and I'm going to see if I can get them out. And if you have any other questions, just type them in. I just want to scroll up here and see if we can see if we've got them all. One, Jill, your patient in San Francisco is listening in. Shelley.
Oh, hi. I know who this is. Is it Jill A?
Yep. Yes.
Hi, Jill. How are you? Thanks for joining today. I still have a little following in San Francisco. I'm very happy about that and proud.
Yeah, was the size of the tumor-affected area also reviewed? That plays a big part in choosing mastectomy or lumpectomy in addition to the cancer stage.
Mm-hmm.
So
yeah, that's true. Jill, that's absolutely right, but it doesn't play a big part.
Actually, from somebody else, from Kimberly.
Oh, yes. It absolutely plays a big part in whether you have a mastectomy or not for the side that you have cancer in. But we didn't think that it was directly related to the decision about whether patients chose to have the other breast removed. And remember, it's the other healthy breast that doesn't have cancer that we're talking about.
Okay. And has this data hasn't been published yet, correct?
It has. Yeah, it just came out in JCO last month.
Okay, that's right. I know that. Why did I say that? It's because somebody asked if it had been published.
And actually, you know, I should send you the PDF so you can distribute it on your website.
That's good. We'll share. Were people asked about surgical complications such as infections, rejection of an implant, etc.?
Yeah, we actually have a lot of that information, and we hope to publish that in the next series of papers we're going to that will be coming out of this data set. But you know, we didn't find any surprises. There were a lot of patients who had a lot of regret about choosing to have you know, more surgery than they actually needed if they had a lot of complications. Obviously, if we knew of a way to prevent any complications from happening, that's what we would want for all of our patients. But you know, unfortunately, sometimes complications and sometimes bad ones happen with reconstruction, and that's all part of making that informed decision. But all other things being equal, the women who had reconstruction still felt better about their quality of life than women who had not.
Here's another question. Will you resurvey the same people in 5 years, etc.?
Oh my gosh, I would love it if it was possible to do that. And we could even match for the same patients to see if their perspective changed over time.
Right.
You know, in this one, we only asked women for their survey responses at one point in time, and some women were 6 months out from surgery, and some women were 15 years out from surgery. So it was hard to really compare, but that would be a beautiful study if we could have women retake the survey again in a few years. And Susan, I hope you'll I hope you'll forgive me for saying this, but we're actually really interested in a different survey where we want to ask patients about out-of-pocket costs and how it affected them financially. because that was one quality of life metric that we did not collect because that was not part of the breast Q. But in our group, in our research group, we're really interested, you know, healthcare costs are the #1 cause of foreclosure in the United States. And we're actually really interested to know how going through the breast cancer treatment impacted patients financially, what their out-of-pocket costs were like, what kinds of trade-offs financially they had to make in their lives, because that's another one of those quality of life things that we will never be able to understand unless we ask the patients who've been through it. So hopefully we can get participation again.
Yeah, it's one of the things doctors just tend not to think about. It's not that they're evil, it just doesn't occur to them.
No. And it's possible that we might learn from you and the Army of Women that if we had those discussions up front, women might make different kinds of decisions.
Here's another one. Please let us know your conclusions about body image with and without implants. Thank you. That's from Jane.
So that's a really good question, and we actually did do a little bit of that analysis in the first paper we published. So that was just kind of like a general overview, and it turned out that women who had mastectomy were least happy with their body image if they had no reconstruction, but they were most happy with their body image if they'd had tissue-based reconstruction, so using their own tissue to make a new breast. The ones in the middle were the ones who had the implants, and they were, you know, if you compare between women who had implants and women who had autologous reconstruction, the women with implants were a lot less happy, both in the short term as well as in the long term. Yeah, but it's a lot more surgery and a lot more potential complications too.
Okay, here's another question from Deborah. Given that CPM doesn't improve outcomes in terms of new cancer in the contralateral breast for patients with no genetic predisposition, and now given this quality of life study, how can surgeons justify doing what appears to be unnecessary prophylactic mastectomies? And then that was echoed by Diane.
So I really love this progressive group because most of the time, and I'm not saying all the time, but most of the time when a CPM is done, it's because patients want to have it done, not because doctors are trying to talk them into doing it. And as I started off this conversation, it's a big concern for us when we go to our, you know, we have a American Society of Breast Surgeons meeting coming up, and we'll be talking about this again. We're all concerned about the fact that women are coming to us wanting to have a healthy breast removed, and we're questioning whether we're doing a good enough job educating our patients about how little they may benefit from doing that. I think we're battling things like the Angelina Jolie effect, although she obviously was a BRCA mutation carrier. It's a very different situation, but for a lot of patients, that kind of, you know, it all kind of comes together as a general recommendation that removing both breasts is the right thing to do. So we're battling against a lot of fear, a lot of misinformation, and it's tough going. And I cannot argue with a patient who is very worried, especially if she has a mother who died of breast cancer, even if they're not genetic mutation carriers. It's, you know, I don't see my job as being somebody who should stand in the way and prevent women from doing this, but I make my biases known. I make patient, you know, I come clean and tell them that my personal bias is to only do the amount of surgery that's required to cure them and not to try to do more than that amount. And then I explain all the reasons that I feel that way. And if I feel like I've educated the patient, they know the data, and they still decide that they want to do a bilateral mastectomy, then that's what I'll do for them.
Well, that sort of goes with the next question, which was anxiety about getting cancer in the healthy breast the only factor you analyzed for the reason behind the CPM? Were women asked why they were choosing CPM, or was the assumption that it was for reasons of anxiety? She says, I made a choice for CPM, but it wasn't really based on anxiety, so wondering if other reasons were offered.
You know, I wish we'd talked to you before we did this survey, but because this wasn't a survey just about CPM, we did not ask women why they did it, but I really wish we'd had, because I think that would have been so interesting to be able to report. We were looking at all women who had all different kinds of breast cancer surgery, so we didn't have one that was specifically about why they chose to have CPM, but I really, if I were to do it over, I really would want to ask that. Very important.
And then Pamela says, is the increase in psychosocial well-being over time statistically significant?
Yes, it was.
Okay.
It was.
Did you look for
the lack of improvement in breast satisfaction was also completely not significant, meaning that there was no difference over time in how much happier you are with your breast, but definitely you're overall much happier with your just psychosocial, just being in the world.
Did you look for a correlation between having CPM and family history or type, like lobular or ductal?
Yes, we look for those sorts of associations, and there was a weak association with family history, but not with the type of breast cancer.
Okay, and how about previous histories of ADH or ALH?
We actually did not. We did not collect that.
Okay.
But that's a good thought also.
Were there differences in these factors between women who had BRCA and those did not? These were all women who didn't, weren't they?
We had a few that did have a BRCA mutation, but if they reported that they had, we took them out of the analysis. We just wanted to include patients who had a non-genetic kind of breast cancer.
Okay.
But, you know, I mean, if patients didn't know or they didn't include that in their survey, then there could be a few that snuck in that did have a genetic mutation.
In your questionnaire, were there any questions about how your decision on having CPM was based on media Hollywood stars going to the Angelina Jolie place?
We actually administered this survey about 3 years ago, so that predated a lot of the media attention around it. But yes, again, I think that speaks to an earlier question of did you ask women why they chose to do it? And unfortunately, we didn't, and I really wish we could go back and ask that.
Okay. Then another question about whether there's a mix of BRCA from Pamela, which we answered. Jill, your friend Jill says yes, she love you. Lisa,
I love you too, Jill.
and Lisa Feldstein is also on, who's another fan.
Oh, Lisa, oh my goodness, oh my goodness. I love you too, Lisa. Oh my gosh. This is so fun.
Here's another question.
So fun.
From Jane. There's so much pressure to have reconstruction surgery. I would like to see more data on what the trade-offs are with and without. I do believe that self-esteem, age, and a healthy body image impact this decision. I'd personally like to see women not feel the pressure to go through reconstruction. Plastic surgeons make us feel so weird if we opt not to, and I'm so glad I didn't. I have half of a woman's chest with my healthy breast, and half as a jock. My pecs are gorgeous under my scars.
You know, I think that was one of the most important comments that I heard today, because I think a very nice-looking mastectomy incision is equally aesthetically pleasing as a well-reconstructed breast. So I think that's really important that you brought this to, you know, reminded me that I needed to make this point, is that regardless of what we saw in this paper, my personal experience in my practice is if I have a very grounded, centered individual who is completely happy and comfortable with herself without a reconstruction, that's my happiest patient. Most people are not there, though, and most people feel that there's something lacking in themselves because of everything around them, the media, you know, their family, their plastic surgeon, their breast surgeon. I mean, everyone, you're right, makes them feel like there's something wrong if they don't want to have reconstruction. And many people are just kind of, you know, they're on that track, and they don't have the self-awareness and maybe sometimes self-esteem to stand up to all that and say, hey, you know, I am completely fine without having a reconstruction. So I have to say, if you're that individual, you're the happiest patient in my practice, and you have the fewer side effects, you have the fewest physical limitations, and good for you. I'm so happy you said something.
And then Deborah Collier has a great question, which is one I was going to bring.
Oh, hi, Deb.
What about losing healing? I think that so often I hear people tell me that the plastic surgeon or the general surgeon says, oh, it'll look normal and it'll feel normal. And they mean to the feeler, not the feelee. And I think the loss of sensation and not being able to hug or feel somebody you're hugging and things like that is dismissed often by surgeons.
And yes, Deb, in that New York Times article, I'm so happy that they made this point that one of the reasons I did this study was because I was really moved by something that one of my patients said, which is that she couldn't feel hugs anymore.
Yeah.
And that just kind of went straight to my heart, you know, in a way that all the data in the world really doesn't. So you're right, and I think the trade-offs that are involved in all of these sorts of invasive treatment decisions that we make or that we recommend, I mean, they all have to be, these decisions all have to be made in the context of trade-offs. And I think this is a step, you know, this study is a step in the right direction. Obviously, we have to have a lot better refined tools to be able to get at some of the questions that a lot of you have asked. But I think it's at least a step in the right direction where we're starting to ask the patients who are in the best position to know what it feels like after having made this decision. And I think what we learned is that, you know, you do more surgery than you need, and not only do you not live longer, but you probably are not happier either.
Yeah.
So I think if that is a message that can be communicated to patients, I think I don't care what decision the patient makes, I'll make it the best decision that I can make it. But I think when patients are making the decision, they need to know that this kind of data is out there, and they hopefully will not have the expectation that they will end up with a more gorgeous set of breasts and they'll just be happier and less worried, because the data shows that that's just not the case.
That being said, which is a good segue to Debbie's comment, that there is a benefit that is not just health-based. I had CPM because I wanted symmetrical breasts and had a tram flap and could only do the procedure once and did not want to worry about starting the whole thing over again at a later date with the remaining breast. So she was happy. And then Nora says she's heard from a lot of young women with new reconstructions that they have quite a bit of sensation, unlike I do. So it's, you know, I think there's some mixed feelings, and we should end with Catherine's comment. Thank you for providing feedback on the study. Wonderful presentation and great questions by the participants.
And I would like to echo that. I really just am so grateful for the opportunity to be able to do this study, to ask this question, and then to return the results back to you. I think it's been very special for me.
Well, thank you very much, Shelley, and we look forward to working with you further on more studies through the Army of Women.
Thank you so much, Dr. Love. Thanks to all the participants as well. Have a nice afternoon.
Thank you, everyone. And
bye.
And the recording it will be up sometime tomorrow, and we'll get both a personal email with the recording, and then it'll be up on our website for the end of time.
And thanks to all my friends on the call. All right, terrific, everybody. Take care. Bye-bye.
Bye.